So good morning, everyone, and welcome to this first webinar on the Swiss DolorClast method. We are very excited and very happy today for this first event of its kind, and we are also happy to bring you some positive vibes in this special period. Before starting this webinar, I would like to introduce myself. So my name is Mary-Christine Colette. I'm responsible for training activities around the Swiss DolorClast Academy. So the Swiss DolorClast Academy, known as the SDCA, is the organization of the company EMS Electromedical Systems, which was created in 2013. So this training organization created in 2013 is offering shockwave training programs worldwide to users and trains the experts of tomorrow in shockwave therapy. So EMS, the company EMS, invented the Swiss DolorClast method at the end of the 90s. So to get back to our webinar, we are welcoming today Daniel Morgan, our expert of the day in shockwave therapy. Daniel, good morning.
Morning.
So
morning.
I will leave you the mic in a few minutes so you can introduce yourself. So just a couple of technical points for our participants. So we will have 15 minutes before the end of the webinar for the potential questions you may have on the Swiss DolorClast method. So please feel free to use the Q&A section at the top or the bottom of your screen. And you can also use the chat section at the bottom or the top of the screen. And we will, of course, answer your questions after Daniel's presentation within 40 to 45 minutes. So I think it's fine for now. Daniel, off you go. This is your time. The stage is yours.
Cool. Okay. Thank you. Thank you, MC. I think I really want to start as well by saying thanks to EMS, because we're obviously trying to continue to provide a good standard of education and shockwave education at the moment, and it's obviously really difficult with everything that's going on. And MC she solely really runs the educational perspective for Swiss DolorClast. So I think a lot of thanks has to be said to MC and EMS for trying to put these on and continue the education, because MC is responsible for most, if not all, of the education in the UK, but also across the world. So yeah, so thank you for doing that, and I'm sure everyone else will reciprocate those thanks. So just want to check now that you can all kind of see. I'm going to introduce myself. I'm a chiropractor by background, and I practice at Beaches Chiropractic in Port Talbot, South Wales. In 2018, I was lucky enough to be voted British Chiropractic Association Associate of the Year, and the following year I then completed my Masters in Sports and Exercise Medicine and postgraduate certificate in medical ultrasound at the same time. So I've got a background in sonography as well, which is really handy when it comes to treating tendons, as is the sport and exercise medicine background for the rehab kind of stuff. This year, I've also been appointed the Director of Academic Affairs for the Royal College of Chiropractors in the sports faculty. So that was an honour to be appointed that role. So that's just a little bit about me, but it's kind of irrelevant really when it comes to shockwave usage. I've been teaching and lecturing shockwave now for 3 years with EMS, and it's really the introduction of shockwave into our work clinic has been instrumental. It's really changed our practice drastically. It's certainly changed the way that we would manage these typically stubborn conditions. So the things that we would usually use Shockwave for is fasciopathies, tendinopathies, and sometimes just those little obscure ones, and they're a little bit out of the box, but will stick within the box for the process of today's talk. And yeah, I think hopefully you guys get using Shockwave. If you're not already using Shockwave, it will give you a perfect adjunct to what you're already doing, and it will give you more for those stubborn conditions. So today we're going to talk a little bit about the Swiss DolorClast Academy. I know MC has touched on that a little bit. We're going to look at what are shockwaves, what is the physics behind it, the Swiss DolorClast machines, how do they differ to other machines possibly on the market, the process of the cavitation and how does it work, so the actual mechanisms behind the pathology really, so how do we affect the pathology, and then we'll have a little look at the literature. So the PEDRO database is out there, and a few other literature reviews have obviously been carried out, but we're going to stick to the PEDRO database for today. And then at the end, you'll have ample opportunity to grill me and ask as many questions as you can or as you like. So from the Swiss DolorClast Academy perspective, we are very fortunate that we're able to provide top quality education. In my opinion, very biased, but we are able to provide some good education across the world. We put together tailored training programs, and we train people on the Swiss DolorClast method. We have over 200 courses per year. We have 70 official trainers from 24 different countries, and there are over 5,000 certified practitioners in more than 30 countries. So the Swiss DolorClast Academy ranges globally, and it is nice to be a part of. What it does is you can add your practice to the online directory of Shockwave centers and Shockwave users. So it really does increase your exposure. You can drive business to you and your practice. And we add you to this online directory, and you can get, even if you're struggling, what it does do is that you can actually just go, okay, well, who else uses Shockwave in the area, or who else uses Shockwave that I can maybe pick their brains. So it's not only for driving business towards you, it also is useful for actually helping and asking for advice. Recently, Chris is UK sales manager. He comes to all the courses with us as well. So Chris is, we'd be lost without him. I wouldn't usually tell him that, but we would. And what we do is, obviously, we get everyone together in the courses, but we have since set up a Facebook group as well. And that, if you're a Swiss DolorClast user, you can join openly, and that gives you a really good platform to discuss some difficult cases. So really, really useful tools to have at your disposal with being a part of the Swiss DolorClast Academy. So without further ado, we're going to get into a little bit of a video just to introduce the Swiss DolorClast Academy in more detail, and then we'll get on to the physics. Okay, so I think that there's actually no sound with that video, but the video is available online. There's nothing important in that video. All it is just a little introduction to the Swiss DolorClast Academy. However, that video is available on the website, it's available on YouTube, so don't panic about that. So there's been a lot of talk about shockwaves and shockwave therapy, but we want to start off by saying, what is shockwave? And it's basically high pressure sound waves. So a lot of people without any knowledge of shockwave will assume that shocks includes electric impulses, and that's not true. They differ, shockwaves differ to other sound waves as they are high intensity sound waves and generated at extremely high pressures. So if we look at day-to-day examples of that, that would be aeroplanes breaking the sound barriers, earthquakes, they produce primary shockwaves, secondary shockwaves, and explosions. And explosions are one of the best ways that we can really show you what the effects of a shockwave. And one of the key things that we need to know is that shockwaves have very little energy dissipation through water. And this goes all the way back to the early uses and early applications of shockwave therapy, where we were testing its uses on ceramics. And we actually used shockwave, an applicator or a handpiece, dunked it into water, and then delivered energy into ceramic tiles. And we discovered that, okay, yeah, great, we can break things. And this is obviously very much in a lab environment, but they found that it had this destructive protocol. And it's actually from there that we developed lithotripsy, and then from there we developed more education and more research into musculoskeletal conditions in the early 90s. So early studies were all involving water baths. Now, obviously, electricity and water isn't deemed safe anymore for obvious reasons. And we now have other means of using water or water-based substances. So we at EMS have a contact medium, which will come with your machines. And that contact medium is a water-based substance, and it allows those energies to really penetrate further. And one of the best ways that we can actually show this is through explosions. So this is a explosion that is obviously taking place in an air-filled environment, so out in the open. And the key thing here is that you're seeing ripples of the orange balloon and very little ripple going on with that red balloon. And actually in the other part of that video, you could see that the closer balloons have actually been destroyed. So what that's showing is that energy is lost the further away from the charge. Now, it's not an ideal representation because, again, this is a different video with possibly a different charge. However, if we look at this in water, there's a significant difference on how the charge affects the balloons across a wider range. Now, they may not be equal distance as the one in the other video, but you can see that the yellow balloon is having the charge is having a very similar effect on that yellow balloon compared to the purple balloon at the front. So that's why we use a contact medium. That's why we use water-based substances. Other people have been, well, they have used castor oil. It actually gets really messy. But this contact gel is amazing for that. The purpose of this one is that it actually contains less air bubbles in theory, which is going to dissipate less energy as well. So that's the reason as to why EMS use the contact medium as opposed to other water-based modalities or such as ultrasound gel, really. So from a physics perspective, we often get asked the difference between shockwave therapy and ultrasound. And the truth is that there is a significant difference from a physics perspective as well as an outcome perspective. So shockwaves are basically defined by 4 key points. It's a high positive peak pressure. It has an extremely fast rise time. Then we have this very short period of negative pressure, and all of this happens over a very short period of time. So there's a short life cycle. And this is a physical representation of a shock wave. That's a physics perspective, what the wave looks like. Now, you compare that to ultrasound, and ultrasound waves are more of an oscillator. They have significantly less energy being produced. There is a longer cycle. And the ultimate difference is that there's really less physical effect on the medium in which it passes through. So in this case, that is the tendon, the tissue, the muscle, whatever it is that you are directing that energy towards. Shock waves have a really, really high energy through that medium. Ultrasound has significantly less. So if you are familiar with shockwave therapy, you will know that there are 2 types. And they are, shockwave is an umbrella term, and they are defined as focused shockwave and radial shockwave therapy. Now, the only thing that is different between them is the energy and how that energy is delivered. So focused can deliver more energy than radial shockwave. However, radial shockwave is more often than not an ample resource. It's really good for treating tendons and plantar fascia issues. And the reason for that, we'll explain a little bit later, is that it works in the peak energy forces, or the peak energy fields that affect tendons, really. But focused shockwave is different in its delivery because it starts really broad at the applicator head and then becomes more focused. So it's your Ronsil, it's exactly what it says on the tin. It becomes more focused the deeper and closer to the pathological tissue that we are going. Whereas radial has this more of a torchlight effect. So the applicator head is down the bottom and then it actually dissipates outwards. So that is the differences in how focused shockwave is applied compared to radial shockwave. But ultimately, from the perspective of research and reviews, more often than not, radial shockwave does a job. Sometimes focused, because it can deliver more energy, is used for those stubborn conditions, particularly with calcific tendinopathies, or maybe just really, really stubborn plantar fasciopathies. So there is scope for focused, but radial is equally as beneficial. So we'll talk about the settings and the type of, obviously, the settings that can be changed. Now, energy is one of the things that I've already discussed in saying that focus can deliver more energy than radial. And the way that energy is defined is usually energy flux density max. So that is millijoules per millimeter squared. Now, it's a definition that is the maximum power delivered through a defined surface area, and that is dependent on the applicator size. So I will show you the applicators. I've got the applicators with me, and I'll show you them, and I think they're in the next slide or in a couple of slides to come. And what we will do is we'll discuss the appropriate use of each applicator and obviously why it's important. So on the machines, energies are represented as either pressure or energy. Now, this is really important, and we'll come to the significance of this later on. But with a master touch unit that is currently available, we can alter bar to energy, because what happens is, if you look at some of the literature methodology will say, oh, we use 4 bar at 15 hertz for 2000 impulses. Now, other literature will say we use 0.18 millijoules per millimeter squared. And there's a conversion, and the Master Touch actually converts that for you. So if you are looking at literature and want to replicate the literature methodologies, then that comes in really handy. Otherwise, there is a conversion chart that is also available. We can obviously change frequencies, which is the number of shockwaves that are delivered per second. And the machines will typically provide you between 1 and 20 hertz. Now, the Smart 20 unit, which again, I'll show you in a minute, is a little bit less personal. So by that, I mean it has less of an interactive interface. But we will be able to deliver 4, 8, 12, and 20 hertz with the Smart 20, whereas the Master Touch can deliver anywhere between 1 and 20 hertz. Realistically, the majority of your treatments will be carried out between 8 and 12 hertz. So again, either machine can give you the ample settings and just a little bit less personal with the personalized with the Smart 20 unit. Now shocks, I should change that to impulses, because shocks, as I said, does imply electrical impulses, and that's not the case. The number of impulses that are applied during a treatment is essentially the number of shocks and impulses that you will provide. So typically for a treatment, we will be looking at 1,500 to 2,500 impulses. However, that may differ. And the reason why we say that may differ, it will differ between conditions, it will differ between whether or not you decide to use trigger points treatment in your normal scope and your normal protocols. However, if you want to know more about those, I think that the hands-on courses are perfect for that. And this year as well, we've also run out the first advanced rehab course as well. So we touch upon angles a little bit more, because the angles are the specific angle at which we apply the shockwave is really important, because ultimately shockwaves can only affect the tissue that it's aimed at. So the hands-on courses will tell you more about the specific protocols, but they will differ, and we'll talk a little bit about appropriate uses of applicator heads, etc. But the advanced lower limb tendinopathy course we ran in January, it went really well, and I think we are looking to do more when we get back to normality, so that's really good. But yeah, we touch upon trigger point usage, and I think trigger point therapy is something that not everyone does, and treatment of trigger points isn't something that everyone does. However, there are some research out there now, well, not written down research, but there are some people who are quite experienced in the use of shockwave therapy are using the applicators for the treatment of trigger points and getting maybe 10 to 20% better outcomes. So that's quite interesting. So here's the Master Touch machine and the Master unit that we were talking about. As you can see, it's a touch screen interface, and it's a really nice and interactive. You have your pressure, which is 3 bar at the top there, 2,000 impulses. Frequencies, which is on a sliding scale between 1 and 20 hertz, and then the applicator size. And the applicator size is important because of the energy that is delivered through that defined applicator size. So it's not highlighted here, but in the bottom right hand side of that screen, you have a little button called energy, and you can press that. And what that does is it changes the pressure from bar to millijoules per millimeter squared. So that does it really nicely for you. It's a lot less brain work, and you haven't got to go digging around for a conversion chart. However, this unit, the Smart 20, has exactly the same performance. You can get the same outcomes. It has the same external compressor, has the same handpiece, so it's consistent. The only thing is that it's less interactive on its interface. Again, this is touchscreen. The pressure unit on the left hand, the circle, is like a little dial tone, the old dial tones on the phones. So that works really nice again, and you can progress through from 1.5 bar all the way up to 4 bar. So again, same performance levels. The shocks, you cannot deliver up to the 10,000 in one consecutive. But realistically, for neuromusculoskeletal conditions, you don't need more than the 2.5 to 3,000. You only really go up to the 10,000 for things like cellulite reduction and whatever else. But that is, again, outside of our usual scope of practice. So as I said, frequencies 4, 8, 12, and 20 hertz are the frequencies that you can deliver with this unit. Okay, so the applicator sizes. This is really important because we talk about energies that are delivered into the tissue, and it's defined, the maximum energy is defined dependent on that surface area. So we typically use two applicator heads, which is the 15 millimeter and the 36 millimeter head. Now this is, let me get my aim right, this is the 15 millimeter applicator, and this is the 36 millimeter applicator. Okay, so the 36 mil has 4 times larger surface area, which means that if you were delivering 4 bar with this, the maximum energy density is going to be significantly higher because it's a smaller surface area. Whereas if you're using 4 bar with this, we're going to get a significant reduction in the energy that we are giving to that tissue because we have a larger surface area which that energy is spread over. So the importance of that actually comes when we look at the pathology and what energies respond, or what tissues respond to certain energies. So here's a little conversion chart for you. If we are looking at 2 bar, we are usually delivering 0.06 millijoules per millimeter squared. Now 2.5, we get up into 0.11, 3, 0.13, 3.5, 0.16, and then 4, we're delivering the maximum energy output of any shockwave unit at 0.18. So, well, not any radial unit. Now we compare that to the 36 millimeter head, and as you can see, there is a significant reduction. It's, well, I wouldn't even want to do the maths on that. I think it's 4 times less energy that is delivered. So that is important because we're having a less effect on the tissue, but there is more of a significance to this. And it comes really between what energies affect certain tissues or types of tissues. And we know that tendon generally responds between 0.1 and 0.2 EF millijoules per millimeter squared, which is exactly the energies that are delivered at 2.5 bar up to 4 bar with a 15 millimeter head. With the 36 mil, we're significantly below that. However, that doesn't mean that this can't be useful in the treatment of tendinopathies, because certain patients may be very sensitive. They could be hypersensitive and they can't tolerate that level of energy. So what we do is we use this one. Now, when we use that, that can create some really nice hyperstimulation in there. And it creates this neurological pain reduction. And I'll talk about that in the effects a little bit later on. But it can really cause some hyperstimulation, which then immediately reduces down pain and allows them that little bit of pain relief to maybe progress and start some loading. So if you do have some hypersensitive patients, although we're not technically working within the energy ranges, this is still really useful for pain reduction. So I think realistically, it's better to walk you through that at the hands-on courses. But as a guideline, can come in really useful for those really hypersensitive patients. So how does it work? And the current evidence base suggests that there's an interplay between mechanical effects, biochemical effects, and pain relief mechanisms. And that hyperstimulation comes into that pain relief mechanism that we were talking about there. But we'll touch on each of these individually, and we'll look at the mechanical effects first. So this again is a representation of a shockwave. We have that light blue area is the positive energy, energy density, and then the dark blue area is the negative energy density. Now, the light blue area is where it's that really fast rise time and the positive peak pressures that we talked about right at the very beginning. And this is where we actually see the compression phase of shockwave. So what happens during this phase is that we create shearing stress to the tissue, and this is responsible for a process called mechanotransduction. And ultimately, that process then leads to the chemical responses and the pathway that leads on from there, the cascade of events really that leads to the pathological healing. So that is a really important phase. So once we have that compression phase, we do get mechanotransduction, which leads to a cascade of events. However, the tensile phase is where we actually get the production of cavitation. Now, if you know anything about shockwave therapy, cavitation will be talked about quite a lot. And it's quite rightly so. It's really important that your unit is producing cavitation, because cavitation is responsible for, again, more energy that is being delivered into that tissue. So it creates more of a secondary shockwaves as well, which we can show you doing shadowography. So shadowography is an imaging technique that we capture a shockwave. But the total, obviously what we're looking at here is the total energy density is a combination of the positive energy density and the negative energy density. But it's that tensile phase that is responsible for the production of cavitation. And if your unit isn't really producing a cavitation, then we're not having really significant effects onto the tissue, and it doesn't really give you. We know that like massage applicator heads don't produce cavitation, and therefore there's less energy and less outcome or less significant outcomes with those applicator heads. So this is what a cavitation looks like in a glass bottle or a plastic bottle. Now this is the old classic unit, and these are still in circulation today. I mean, they've been going on for a number of years. I think 16 years, maybe more. Now this is 2-bar, 15 hertz, 2,500 impulses, and as you can see, there is nice production of bubbles and cavitation within that water. Same thing at 2.5 bar, we're getting more bubbles, more cavitation being produced. 3 bar is a little bit above 3 bar, but 3 bar, again, more cavitation filling that glass or plastic. And right the way up to 4 bar, higher amounts of cavitation, higher amounts of bubbles present within there. So we always get asked questions about this, and one of the trickiest ones that I've ever had was, well, okay, that's well and good, you're showing this in water, but does this happen in the tissue? And I think the key thing that we need to remember is that when you look at tendons from the physiology, 80% of a tendon is actually water. So for us to demonstrate it in a glass full of water, that's a completely appropriate thing to do, because actually 80% of the tendon weight or mass is water. The 20% of it is dry weight, which is your collagen etc., etc. Now, how does that look on shadowography? Hopefully this will work. There you go. So that is a really slow example of one single impulse. Now I'll break that down a little bit more, but here we have this compression phase and then the tensile phase producing cavitation. So we'll see that again. Compression phase first, tensile phase, bubbles produced, and then secondary shock waves are also being produced. So in the early phase, that first dark line that we were seeing is the compression phase. Now, this is where we have that mechanotransduction and we get the the compression of and shearing forces through the mitochondria and the cell membranes. It's during the late phase that the cavitation is produced. And what's interesting is that if you can really look at that, you can see other circular patterns that are present within that. And that is because the cavitation has produced secondary shock waves. And this is how it has that greater energy output or greater effect. Because the cavitation, obviously, a bubble pops, it then produces secondary shock waves within that element, which is, again, if you're only producing one, there's less effect and less mechanical effect on that tissue. I hope that makes sense for everyone. So this is it's all about cavitation, and what we've discussed mainly has been on the Evo Blue hand piece. It's also important to recognize that EMS and Swiss DolorClast do have a Power Plus. What I will say is that Power Plus handpiece is often used on horses. So it does have significantly higher energy outputs, whereas the Evo Blue can deliver 0.18 millijoules per millimeter squared. The Power Plus can deliver up to 0.4. So it has significantly higher energies. And again, this is also one of the options that if you do have one of those stubborn conditions, the Power handpiece may be useful. But the majority of conditions will absolutely respond to the Evo Blue at 4 bar. But that's not the purpose of this slide. The purpose of this slide is to demonstrate the amount of cavitation that is being produced. This study was done in 2015, and what it was basically highlighting is that there is significantly higher amount of cavitation being produced with the Evo Blue and the Power handpiece compared to other competitors. So this is why I was saying that if your handpiece isn't producing cavitation, or if your applicator isn't producing cavitation, then realistically we want to be considering how much of a mechanical effect that's having on that tissue. So again, we're going to get into now the nitty-gritty of how it works. And what we know is that shockwave induces angiogenesis. It has a pro-inflammatory effect. We do get an immediate pain relief often with patients, and I'd say that that's actually one of the good indicators as to whether or not a patient will respond. And then we also hopefully get this long-term pain reduction. We liken the immediate pain relief perspective to the red hot chili peppers, because for those of you that like chili, have you ever had a chili and you take a bite of it and it's like, oh my god, that's really hot, and then actually this is hurting now, and after a while you can no longer taste anything because it becomes numb, and that's due to the effects of obviously the chili, and it's hyperstimulated the taste buds. And that's the hyperstimulation element that we were talking about with the 36 millimeter head. So we stimulate it to a point where actually it's now desensitized. So we'll talk about that. Firstly, we'll touch on the angiogenesis. And what we know is that studies have highlighted that there is increase in vascular endothelial growth factor at the bone tendon junction, and this was done with rabbits in 2013. Then in 2006, it was identified that there's a increase in angiogenic growth factors as well. So you get your vascular endothelial growth factor, the eNOS is increased. And these substances are responsible for inducing neovascular changes within that tissue. We also know, interestingly, that there was increased activation of proliferating cell nuclear antigens, and increased stem cell activation. So that's really interesting from the perspective of the effects of shockwave therapy. From a pro-inflammatory effect, I think it's really important as well, because what we usually treat is chronic conditions. So we know that there is a immediate increase in interleukin 6 and interleukin 8. There's a 5-fold increase in metalloproteinase 2 and 5. And it's these chemical responses that ultimately lead to increased tendon homeostasis, and they increase the fibroblast activity as well as pathological tissue destruction. And it is because of this that we say no naproxen, no ibuprofen, no anti-inflammatories or NSAIDs during the course of treatment. But also, for me, I actually say 2 weeks prior, we want to ease away from them. So that's the key point to take from the fact that we have pro-inflammatory effects. Because if the patient is on anti-inflammatories, you're undoing that inflammatory response that we want to induce to be able to promote healing. So pain management as well. We know that there's a reduction in substance P and reduced calcitonin gene-related peptide when there is prolonged activation of the C nerve fibers. So what also happens is that there's a reduced neurogenic inflammatory response, and I'll show you this in a little diagram. But what happens is between the first order neuron and the second order neuron, the substance P is transmitted. And I'll show you that in the little diagram next, but there's a complete reduction of substance P at the spinal cord. So between that first order neuron and the second order neuron, substance P is reduced, which means that that second order neuron isn't sending as many signals to the brain, hence how the brain's interpretation of pain is reduced. We also get a temporary selective destruction of unmyelinated nerve fibers here, and those nerve fibers are responsible for the pain sensation at the periphery, really. So here's what I was talking about, if you couldn't quite visualize that. We have that afferent nerve fiber, the first order neuron, and then we get the pain neurotransmitter substance P being released at the spinal cord at the dorsal horn. Now, that second order neuron is obviously sending signals up the spinal cord and into the brain, which then stimulates the brain's response. Now, because we are reducing the substance P at the spinal, at the dorsal horn, there's less opportunity for that second order neuron to actually send signals up into the brain. So that's the neurogenic inflammatory response that we were talking about. So we've talked about how it works, but I think it's really important that you know what to use it on. Hence, we'll now talk about the indications, contraindications, and when to use it, when's it appropriate, when isn't it appropriate. And indications are recognized condition that is known to be responsive to shockwave therapy. And NICE do state that there is a confirmed diagnosis via MRI or diagnostic ultrasound is preferred, but it's not essential. I think that often a clinical diagnosis is significant enough. I have the added benefit of having ultrasound next to my shockwave machine. So I do a lot of ultrasound with my tendinopathies to rule out interstitial tearing, etc. There's no real contraindication to that. However, it just gives us a better indication as to whether or not that patient will respond long-term, short-term. I find that personally, interstitial tears or some micro tears, they tend to take that little bit longer and they're a little bit less favorable in terms of outcomes. However, sometimes it's an appropriate decision to make to treat them using shockwave. But that is the benefit of having the ultrasound or the MRI in those cases, but it's not essential. So pain, typically, if you've had pain for longer than 3 months or longer than 6 months in some cases, the Achilles, for example, has been highlighted that if you wait for longer than 6 months, you can get better outcomes. If a patient has failed conservative management, then shockwave is absolutely appropriate to try as an next protocol. Also, if a patient requires surgical intervention or more invasive procedures, then injections, for example, shockwave therapy is again appropriate at this point. And also if there are no known contraindications to care. So all of the others basically doesn't matter if a patient has a contraindication. Sometimes it's worth discussing that with your co-management, you know, in a multidisciplinary team. So if a patient has a pacemaker, for example, you may want to discuss that with a cardio surgeon to see, and you're treating the shoulder. You may want to speak to them first to make sure you get, you know, give away some go ahead. In my opinion, I probably would just ease off because of litigation. But sometimes it's worth having those discussions, because whoever's in control and has management or control of that patient's management may actually say, yeah, okay, we can give it a go, providing X, Y, and Z is carried out. However, contraindications. So we shouldn't provide shockwave therapy over the following regions or for the following conditions. Now, we shouldn't do it over airfilled regions, and this actually goes right the way back to the discovery of shockwave therapy, or well, shockwaves. In World War II, what we were finding, I say we, what medics were finding in World War II, was that there were a lot of people that were presenting with internal injuries, pneumothorax or abdominal injuries, without any real signs of external cuts, bruises, anything. And it's actually because the explosions going off, detonating, were producing shockwaves which were damaging internal structures. And the key thing here is that air-filled regions, that's what the stomach and obviously the lung have in common. Also, early studies carried out in Germany were showing that there are low-level side effects if we use shockwave therapy over the lung, over the abdomen, and also over the brain. So we tend to stay away from those areas because there's shown known side effects for those. We also avoid the treatment of pre-ruptured tendons, pregnancy, patients under 18, and the reason we say that is because of open growth plates. However, Osgood-Schlatter's disease has been shown to be safe and effective. So for the most cases, we say avoid patients under 18 due to the open growth plates. However, if you were treating a patient for Osgood-Schlatter's disease, completely appropriate. The study in question was a poor study, in fairness, and I had to translate it when I was reading it, so it might get lost in translation. But there was very low numbers. There was no control group, so we didn't know whether or not it had a greater outcome compared to conservative management alone. However, what we could take from it was that there was no side effects, or no low-level side effects even, that occurred to that population and that patient sample. So we know that it's safe with that condition. If you were to ask me what's different between Osgood-Schlatter's and Sever's, you know, other than obviously the location, I don't know, but because we haven't shown that it's safe and effective for that condition, we would stay away from it for now. If patients have blood clotting disorders, we stay away from them. If they're being treated with oral anticoagulants. Definitely if there are tumours or localized infections. If they've had a recent steroid injection as well. So as a rule, we use 6 weeks for the upper limb, 8 weeks for the lower limb. Realistically, you could go less than that. You could wait for 8 weeks consistently across the board if you wanted to. but we'd certainly look at 6 weeks for the upper limb, 8 weeks for the lower limb as a rule. So what conditions would we typically treat? Lateral epicondylitis, medial epicondylitis. We've had a case recently in clinic where we had a gentleman present to us with bilateral medial epicondylitis and lateral epicondylitis. Not ideal circumstances for him. And the next protocol for him was tendon debridement. And he was booked in for that surgery. But the consultant taught me on my master's, and he said, look, you just go and try it. It may help, and it may stop you from going under the knife. So we had 3 sessions. He was very skeptical at first and didn't really want to do both elbows at once because of the pain experience with it. And he said, let's just try the one first and let's see. So he did the one. After 3 sessions, we had a 70% reduction in his pain. So he then said, okay, great, we'll come back and we'll do the other one. So it was a real game changer for that individual. We also can treat subacromial pain. Now, this is one that is up for discussion because literature is actually suggesting that there's no greater benefit to the addition of shockwave therapy for subacromial pain syndrome than conservative management alone. However, anecdotally, we can get some really good outcomes. Now, this is where I think diagnosis is quite important. This subacromial pain is now such a vague condition. We don't know really, is it a bursa, is it a tendinopathy, is there a partial thickness tear? We don't really know what's going on there until we get maybe some imaging, or if we get some confirmation via MRI or ultrasound. Now, in the cases of true tendinopathic change, it can be very useful, okay? But the literature isn't supporting that. So anecdotally, good. From RCTs, not so good. Calcific tendonitis, however, in the shoulder is where shockwave therapy comes into its own. Now, there is significant evidence out there to say that it has greater outcomes than compared to conservative management in its isolation. And the key thing that we need to know is that not all calcific entities respond the same. Now, from a perspective of absorption, we know that if a calcific entity has been there for longer than 11 months and it's larger than 15 millimeters, we are less likely to get a complete absorption of that calcific density. But that doesn't mean that we can't aid function and reduce pain. So from the perspective of what are we gauging outcomes on, I think it's patient-reported outcome measures are more important than actual absorption of that calcium. And that's one thing I think you need to really hone in on your patients, because if you have the benefit of having on-site ultrasound, what we found is that by highlighting the fact that there's a calcium deposit in that tendon, they all want to go, well, let's see the calcium. And so it's very unlikely to have changed if it fits those parameters. So you don't want to reinforce to them that the calcium is the problem, but necessarily it's the function that has been caused, or the functional deficit that has been caused as a result of that calcific deposit. Okay, greater trochanteric pain syndrome. Now, this is a game changer. What we find is that this is your middle-aged patient who tends to be a little bit inactive. And you can really get some good results with shockwave therapy. You have to be very careful with glute max tears. Glute max tears can be particularly debilitating. So again, this comes in with MRI really, or ultrasound, depends on how good you are as a sonographer. But you may want to look at diagnosis if they're not responding, or imaging if they're not responding the way that you would expect with shockwave therapy. Now, patellar tendinopathy is really difficult, not going to lie, it's a really difficult condition to treat. The saving grace with this is that these are always active patients. You don't get a patellar tendinopathy if you're inactive. So these do respond to shockwave and load management. However, what we find is that because these are normally athletes, these are normally in-season athletes. So they're difficult to manage predominantly because they need to be competing. So it's really difficult to take them out of their sport when they develop a patellar tendinopathy, but it is really useful for pain management for them. And sometimes during a season, the patients or the athletes may need to come back and require further treatment, which is fine. So again, this is load related often. So just be aware of that. Osgood Slat, as I said, has been shown to be safe and effective. So good condition and an acceptable condition to treat. Medial tibial stress syndrome is a really difficult one. Chris, who I mentioned earlier, we always use him as the guinea pig for these, and it is quite uncomfortable. I'm sure he'll contest to that. But it is quite an uncomfortable process. It hasn't got to be. We always go to patient tolerance, but it obviously is quite superficial to the tibia, so it can be quite a difficult process, a difficult condition to treat because of that. But again, that's where the 36 mil head can come in quite useful. Achilles tendinopathy, both mid portion and insertional, and they do respond differently. And I think that they do respond equally well, but they do respond differently in terms of their time frames. I think if you look at the actual histology of the Achilles tendon, histologically, the Achilles tendon is completely different at the insertion compared to the mid portion. We have more of a cartilaginous insertion of the Achilles than we do where there's basically a difference in the form of collagen. And we discussed that more in the advanced course, but there is a completely different histological appearance when you look at the insertional Achilles compared to the mid portion. And obviously plantar fasciopathy is kind of your go-to. It's where the abundance of literature is actually lying. So talking about literature, what's the evidence saying? This is the PEDRA database. So the PEDRA database is a physio database. It's actually in partnership with the Chartered Society of Physiotherapy as well. And it's a collection of, when it comes to shockwave therapy, it's a collection of 45 randomized controlled studies or randomized controlled trials. And it's looking at a range of conditions in the evidence and good quality studies and the range of conditions that are available, what's the evidence saying for those conditions. Now, of those studies, there is 80% of those studies were carried out using the Swiss DolorClast machine. And 30 of the 45 studies were using the Swiss DolorClast machine, and 80% of those 30 had positive outcomes. So if you delve into that a little bit deeper, the 20% that didn't, you could possibly criticize on the methodology. Now, for example, we'll pick one, which is Kaplan et al. Now, this wasn't using a Swiss DolorClast machine, but they were treating tennis elbow, and they were using an average of 1.8 bar. Now, even when you look at that from a response of the tendon, that isn't significant enough and high enough to be getting the desired effect on that tissue. So when I treat tennis elbow, I'm going up into 2.5, 2.8, maybe up into 3 bar. So realistically, you can criticize some studies on their methodology. Even though the methodology was carried out well, they weren't delivering enough energy to get positive outcomes. There's 7 studies looking at lateral left condylopathy in this database, and there's 15 studies or 16 studies looking at plantar fasciopathy. So the abundance of literature lies in plantar fasciopathy and lateral left condylopathy, but then there are, there's subacromial pain in there. There's calcifying tendinosis of the shoulder. All of these conditions are available, and all of the studies are listed within that PEDRA database. When you do come on to the Swiss DolorClast Academy courses, we send out an abundance of literature for you to read if you need it, and if you want to do some pre-reading. However, it's also a nice reference for you later on when you are treating. So that is a quick overview of the literature. We do delve into that in more detail on the courses. But that's it from me, really. We'll get onto the question stage now. I think maybe we'll go on to the question stage and we'll go through the conclusion, MC, I think.
Yes, sure. We are a bit running out of time, but we'll have a few minutes to discuss and answer the questions from the participants.
My apologies.
I saw one of them, especially at the beginning. Somebody asked the question, can we apply shockwave on the thoracic region? As I've read in the literature quoting that applying over lung cavity region is contraindicated. However, I see some of my colleagues using it on knee trapeze and rhomboids. Is there any specific setting if we can apply?
So yeah, it's contraindicated over the lung regions. However, I think you do have to be very careful with it. What we tend to do is, again, as I talked about angles, it depends on what you want and what your goal is really when you're using it. Why are you using it in the thoracic region? What for? What we tend to do is avoid perpendicular to the lung. So avoid directing energy directly into it. It is a little bit off scope. I would avoid it in my clinical practice because of the risk to the lung. However, as you said, colleagues do use it and they do actually angle more medially. So they angle towards the spine, which is quite nice. So you can angle it towards the spine. However, I do question what the actual desired outcome is. I'm assuming you're treating facets. And if you are using it, or again, as you said, you could be using it for trapezius and soft tissue work. I don't, but 36 mil head could come in handy there. I tend not to do it in that region though, because exactly as you said, because of the risks.
Thank you, Daniel, for answering this question. Another question concerned, what about treatment in chronic ankle sprain scar tissues, old surgical tendon scar tissues?
Right, so when it comes to scar tissue stuff, it's quite difficult because it's normally old tendon scars are normally pre-ruptured tendons. So that in itself is a contraindication. So I think that's not for me. I wouldn't. When it comes to chronic ligament sprains, absolutely. Yeah, really, really good indication there. You can 100% use it for that. When it comes to I think it's probably better to talk about the actual physical application on the hands-on courses. But yeah, you can use it for the ligament sprains, and you do get some good outcomes with that as well, actually.
Okay, thank you. A couple of other questions. Could shockwave cause a tendon rupture?
So there's no
significant Caroline Hawkins.
There's no significant evidence there to say that the ruptures have been caused from shockwave therapy. I think what happens, and certainly with the reported incidents, is that of ruptures, particularly in the Achilles, the patients have been very poor patient selections, I would argue. So what we're saying is that maybe there's a older patient who has a low quality tendon, and the chances are that maybe there was a partial thickness tear, maybe there was no imaging, maybe there's no diagnostics within those. But there's been 2 reported outcomes or incidents of Achilles rupture, and they were basically when that patient was walking down the steps, a couple of days later. So there's been no direct response to shockwave therapy causing or leading to a rupture. And when you look at actually radial shockwave therapy, the maximum energy that can be delivered is 0.18 millijoules per millimeter squared within the Evo Blue handpiece. So it's a completely safe range that we are working in. So that's the kind of thought process at the moment. I think that it is really important to look at, you know, to really look at the patient selection with those.
Okay, thank you for this answer, a detailed answer. I think we will end with a last question because we are unfortunately running a bit out of time. So last question from Paula Snape. Yeah, we have lots of questions, lots of passion around shockwave therapy. So last question for Paula Snape. How long do you have to wait to treat an area with ESWT after steroid injection?
So after steroid injection, we typically will leave 6 weeks or 8 weeks, depending on the region. So I leave 8 weeks for the lower limb, 6 weeks for the upper limb. Okay. Having said that, there is I think that there was a study going on in Glasgow last year where they were looking at adhesive capsulitis, and they were actually looking to combine hydrodistension and or corticosteroid injection with shockwave therapy, because they were looking to reduce down that immediate pain with the injection and then actually create a mechanical effect onto the capsule following. I don't know if that study ever went ahead, but that was something that was in the pipeline last year. So it'd be interesting to see how they got on actually up in Glasgow with that.
Okay. Thank you for sharing this additional detail about this study in Glasgow. Okay.
Do you want me to go through the conclusion here, MC?
Yes, I think, well, we are, thank you first, Daniel, for your expertise in shockwave therapy. Thank you for sharing and providing this global overview.
Sorry that we ran out of time for questions, my fault. Got a bit carried away.
So you can go on for the conclusion if you...
Yep, no problem. So I think, as we said, to get a better feel for it, you will be better attending the hands-on courses. We are, I think, looking to do maybe more webinars in the future as well. So keep up to date with those and have a look online, and the link is here. For more information, don't hesitate to contact Chris, whose contact details are on the screen. Chris is the UK sales manager, so if this has even spiked your interest in buying a unit, then get in touch with him. Obviously, you can follow the news and follow us on Facebook, YouTube as well. For me personally, I think that you can have a look at my Facebooks and Twitter accounts as well. If you wanted to follow me, then that's absolutely fine. But that's it from us, really. I am sorry that we couldn't get around to more questions. I do apologize. I like to talk.
What we will do is that I will do a listing of all the questions that were asked during the webinar. Yep. And we will keep people informed later after the webinar, so you can access to all the answers and questions. So we will check that after the webinar. So thank you, Daniel. Thank you very much for sharing your expertise. And we will probably plan to have another session, and we'll keep you informed on online on our Facebook or by email. So take care, all of you. Thank you all. Yeah.
Stay safe as well, obviously, at these troublesome times, everyone. So, but thank you for tuning in.
Yeah, thank you, everyone. Thank you for participating. Thank you very much. Bye.
Bye.